Afatinib certainly has been demonstrated robust response rates, progression-free survival, and overall survival for each of our mutant lung cancer patients. I think we always have to be mindful, however, of the toxicities of this drug. It tends to be the TKI with the most adverse events, at least in the data and in the meta-analysis. It does show potentially the most adverse events, and we just have to be mindful of these and comfortable managing them. For Afatinib, I certainly will make dose reductions and be ready to do that, and oftentimes I'll start at 30 milligrams rather than 40 milligrams. It's not uncommon that I have to hold the dose as well. I educate my patients up front about the potential side effects that they may experience, like rash, like diarrhea, like fatigue. I tell my patients to be proactive and get Imodium to manage the diarrhea. I tell my patients about the rash that they may experience. And I think importantly, we bring our patients back frequently when they start this drug. So if we're starting Afatinib on a patient, they are certainly coming back to the office perhaps 2 to 3 weeks later just to check in, and then probably every 2 weeks for at least the first couple of months just to make sure that the AEs have been managed appropriately. I tell my patients to call when they experience these side effects, and I tell them that they will be expecting it. So lots of different ways to manage this. I think being proactive is certainly one, giving your patients the heads up, being ready to manage these appropriately and being educated about how to manage these, being comfortable with dose reductions, and also being comfortable holding the dose to allow patients to recover from these side effects is important. So LUX-Lung 3 and LUX-Lung 6 were 2 phase 3 trials comparing Afatinib to platinum chemotherapy for patients with advanced stage EGFR mutant lung cancer. This trial showed, not surprisingly, an improvement in response rate, an improvement in progression-free survival, an improvement in quality of life when Afatinib was compared to chemotherapy. Afatinib was superior in all of those measures. It did not show an improvement in overall survival in the intention to treat analysis, and that may have been due to the high rate of crossover. However, in a subset analysis of those patients with deletion 19 mutations, there was and this was pre-planned, there was a survival advantage with Afatinib over chemotherapy in both trials and in the pooled analysis. And I think that's important. We've never seen a survival advantage in any subset analysis in a large phase 3 trial like this. I think there are some people who believe that this is not necessarily an Afatinib effect, it's more of a deletion 19 effect. The deletion 19 is a exquisitely sensitive mutation to any TKI you give. And I think we've seen this with both Erlotinib and Afatinib data, but nevertheless, it did show a survival advantage. And I think we have to think about that when we're looking at our patients who are coming in, who are fit, who we think we can manage the AEs for these patients. I think Afatinib is, if they have the deletion 19, should be a consideration based on that survival advantage, but being mindful of the toxicities that may come with the drug. And so these 2 studies did change my treatment approach slightly. For those patients who are younger, fitter, who you're comfortable managing the adverse events that may come with this drug, and they have a deletion 19, I think there should be a consideration for Afatinib. There were some dose reductions in the trial with LUX-Lung 3 and LUX-Lung 6. I believe those dose reductions generally occurred within the first 6 to 8 weeks of therapy. But importantly, that did not sacrifice efficacy when we looked at the overall the intention to treat overall survival, as well as the DEL 19 patient population. I think that what we know is from some data is that dose reductions with this drug don't generally sacrifice efficacy and still lower the adverse event profile. And that's why in my practice, I generally am not hesitant to make a dose reduction or even start at 30 for patients who are eligible for Afatinib. So I think the data suggests that drug efficacy with Afatinib is not sacrificed generally with dose reductions, and that you could perhaps mitigate some of these toxicities. That said, patients even at 30 milligrams can experience significant adverse events, and we have to be mindful. These two, LUX-Lung 3 and LUX-Lung 6, did change the approach for me for my patients. I think Afatinib probably has a little bit of an edge in terms of its efficacy. We just have to be proactive in the way we manage the toxicity, and that does mean potentially starting at a lower dose or making dose reductions for these patients who are on the therapy.